Hi everyone, it's Dr. Sloan, and we're going to talk about drugs for cold and allergies. Hopefully many of these will sound familiar to you because you have probably used them for yourself or for your family members. Okay, so I'm going to just give you a quick list of the prototypes, and I want to see how much you know about them. So over on the left are the list of the prototypes: diphenhydramine, better known as Benadryl; Fluticasone, better known as Flonase; Oxymetazoline. This comes in a number of different formulations, but Afrin might be one that you know. Loratadine, which is Claritin. It's also sold over the counter just as allergy medicine, but if you look at the name of the drug, you'll see Loratadine. And then dextromethorphan. Dextromethorphan, it is a part of Robitussin. Robitussin is probably the best known brand, but I feel like that's misleading because Robitussin has also become like this name of kind of a generic cold flu type medicine that has kind of lots of stuff in it. So we'll talk about that in a bit. But take a look and see what you think. So diphenhydramine is B, an antihistamine. It causes drowsiness. It's what we call a first generation antihistamine, meaning it was the first antihistamine that we discovered and came up with. It's in that group of first medicines that worked as antihistamines. These cross the blood-brain barrier and they tend to make people very sleepy. Sometimes we actually use that sleepiness, we actually use the drug to induce that sleepiness, like for insomnia. So that's diphenhydramine. Fluticasone, Flonase, is a nasal corticosteroid. Remember that sone, O-N-E, on the end. And it is a nasal spray. Oxymetazoline, or Afrin, is a nasal decongestant. Loratadine is also an antihistamine, but it does not cause drowsiness. This drug does not go across the blood-brain barrier. And then dextromethorphan is a cough suppressant, or if we want to be very official in the pharmacology world, we can call it an antitussive, which means that it prevents or blocks cough. Okay, so first we're going to start off with a little bit of Pathophys, just so you know how some of these drugs work. So allergies are really driven by histamine. And histamine is a chemical mediator of inflammation, and it's released from the mast cells. Now, interestingly enough, we have mast cells in a lot of places in our body, but we happen to have a lot of them in our mucous membranes, specifically in our nose, eyes, ears, lungs, anywhere where they could come in contact with outside allergens. So it's really interesting. People with allergies have more mast cells lining their mucosal membranes than people who don't really suffer from allergies. So that might be one reason why they have more trouble, because they have more potential histamine releasers than people who don't have allergies. When histamine is released, it's responsible for increased mucus production and secretion. So think congestion, that horrible plugged up, I can't breathe, talk kind of feeling that you get. It leads to sneezing, runny nose, watery eyes, itching, and that itching can be anywhere. It can be your eyes, your nose, your throat, your skin. Congestion, and again, that is due to increased mucus production and increased fluids and liquids in your mucous membranes. In severe reactions. So think now along the lines of like anaphylaxis. Histamine can cause bronchoconstriction. It can cause significant hypotension, and it can cause edema. So this is why we worry when someone begins to show signs and symptoms of anaphylaxis, which are things like difficulty talking, difficulty breathing, difficulty swallowing, significant tongue or lip swelling, eyes swelling. So trust me, you'll only need to see it once in order to remember what it looks like. So these symptoms here are the more common things that you see with histamine release. You know, you come over to your neighbor's house and you're allergic to cats, and they have a cat, and these are things that may start happening. But in a severe reaction, you could actually begin to have difficulty breathing, swallowing, talking, etc. So just so you can see what happens when histamine is activated, when it's released from mast cells, it causes lots of different things. And this is what we're going to talk about today. So swelling and inflammation for sure, adrenaline release. So if we're having adrenaline release in our system, what are we going to see? We're going to see, that same kind of fight or flight type of reaction. You're going to see perhaps bronchoconstriction. You're going to have dilation of blood vessels, so these big leaky blood vessels. So think about it. We know that in anaphylaxis, patients can have hypotension, so that's where that comes from. It can increase your heart rate. It can increase vessel and capillary permeability, meaning that those spaces between cells, right, that keep fluids and blood in the blood vessel actually loosen up, and fluids can leak out into tissues. It can also cause blood clotting and can also cause the stimulation of gastric acid. So when we talk about peptic ulcers, which we'll do in a bit, this is what it's due to, is this H2 release, histamine release in the stomach, which leads to the stimulation of gastric acid secretion, and then ultimately kind of eats a little hole in your gut, makes a little ulcer. So we're going to talk about allergic rhinitis. This is what a lot of people, especially older people, will call hay fever. Oh, my hay fever's acting up, right? And what they mean is that it typically comes, you can imagine in the old days, it was people who were out harvesting or binding their hay, and all of the allergens from that hay getting, thrown into the air, circulated around, and then someone breathing them in. But that's not the only thing that causes allergic rhinitis. So there are tons of things. And these are just some of the things that set off an allergic reaction in some people. Not all people respond the same way. Some people can be exposed to pollen and be perfectly fine, while someone else gets exposed and is wheezing, has watery eyes, their nose is running, they just feel miserable, okay? But pollen, weeds, grasses, trees. Now think about it. We live in an area where there's 4 seasons right now, so these can tend to be worse at certain times of the year. If you live in a place like Southern California or Florida or somewhere down south where there's not as much of a demarcation between the seasons, you may not see this as much, because these things are either always around or stay at a consistent level. Mold, dust mites, certain foods, and again, really depends on the person. Some people are allergic to shellfish, peanuts, strawberries, which is really interesting, bananas, avocados. It just depends on the person. Animal dander could be dogs, cats, rabbits, guinea pigs, mice, tobacco smoke, and air pollutants. And air pollutants is very broad. That can be everything from air pollution to scents to chemical things that are in the air. It's very interesting. They've done a lot of research on kids who live near freeways. And kids who live near freeways have more allergic rhinitis and asthma than kids who live in suburbs where they're away from large freeway systems. If you think about a child who maybe lives in an inner city area where there's a lot of air pollution, a lot of cars, smoke, maybe factories, they're much more at risk for having a problem. Okay, so you can't talk about drugs for allergies and asthma without talking about histamine receptors. And I want you to know that there are 4 histamine receptors. We are only going to talk about in our class 2, H1 and H2. And actually for this lecture, we're only talking about H1. So we've learned about a lot of receptors, right? We've learned about insulin receptors. We've learned about alpha receptors, beta receptors. Now we have histamine receptors, and that's been shortened to H1 and H2. So H1 is alteration of vascular permeability, extravasation, meaning fluids come out of the vascular spaces, edema, there's adhesion molecules, inflammatory cell migration. So this is what we're talking about when we're talking about allergies, and even some of the symptoms for colds are not necessarily related to histamine, but they can be. So they're usually related, obviously, to a virus, but that in and of itself can be a histamine releaser. So H1 receptor antagonists, so H1 blockers, are targeted for treating allergies. That's what we use the most. And when we get to GI, we'll talk about H2 blockers, things like Zantac, and some of those other things that are H2 related. But right now, for this discussion, we're just going to look at H1. So H1 receptor antagonists, and we might just say H1 blockers or H1 antagonists. They are referred to as antihistamines. However, antihistamine is kind of a catch-all word, right? And it doesn't tell you whether it's anti-1, anti-2, anti-3, anti-4. So that's why we typically, in the pharmaceutical world, refer to H1 antagonists. But when you're talking to your patient, you can say this is an antihistamine, right? They don't need to know that it's an H1 versus an H2 or H3. But for you as nurses, you do need to know that. These meds are often sold over the counter, which will be in the future referred to as OTC in this PowerPoint. They are in many cold flu allergy formulations, so read labels carefully. We've started to sort of synonymize things like NyQuil and Robitussin with, like NyQuil's for the flu and Robitussin's for a cough. But what's happened is those are brand names, and those brands have been taken, and there are a zillion different formulations of Robitussin, NyQuil, all of that. And so the problem is that you can't just say, oh, we're going to give you some Robitussin for this, because Robitussin could have Tylenol in it, it could have an antihistamine, it could have a decongestant, it could have a cough medicine. So we want to be really careful about that. But again, this is these H1 antagonists are often one of the ingredients in these cold and flu formulations. The therapeutic goals when using H1 antagonists, because again, we're looking at it for allergic rhinitis, are to A, prevent the occurrence of allergic rhinitis, and B, relieve symptoms when they occur. So if you're a person who, in the spring when things start to bloom, you always have a runny, itchy nose, and you sneeze a lot, then you would want to start taking some of these medications early, so that you can prevent the onset of those symptoms. It's much harder to treat the symptoms once they occur. So again, you have preventers and you have relievers. So look at preventers. These are used for prophylaxis, in other words, prevention, and include antihistamines, so H1 antagonists, which is what we're talking about, but also intranasal corticosteroids, leukotriene modifiers. Does that sound familiar to anybody? Montelukast, we talked about that with asthma, and mast cell stabilizers. And we're not going to talk about mast cell stabilizers, mostly because they're not super effective. And so we're not going to talk about that in this particular lecture. And then we're going to talk about relievers, things that once you already have the watery eyes, itchy nose, whatever, that will help with some immediate relief for acute allergy symptoms. And oral and intranasal decongestants tend to work the best for that. And we're going to talk about those too. So just as a note, the nurse should really help their patient not only treat allergies, but also identify identify the source of them. Is it a cat? Is it cigarette smoke? And there's a lot of different questionnaires out there. If you were to work in asthma and allergy, you'd learn a lot about how to elicit that information from patients. But a lot of times patients who've had long-standing allergies, they know what their trigger is, what makes them have symptoms. Okay, so there are some other uses for H1 receptor antagonists, and I want to talk about it because you're not just going to see them used for allergic reactions, and they're used for things that are actually pretty darn common. So one is vertigo or motion sickness. It's kind of interesting. Our prototype for H1 receptor antagonist is, I'll just show you, diphenhydramine, Benadryl. But check it out, its close cousin, dimenhydrinate, not diphenhydramine. Dimenhydrinate, better known as Dramamine, is for vertigo or motion sickness, and it suppresses the vomiting center in the brain. So in addition to being, an antihistamine, it also suppresses vomiting in the brain. And if you've ever taken Dramamine, I don't know if anybody has, I've taken it to try to prevent seasickness. But I can remember as a little kid going out on a boat with my dad to go deep sea fishing. And of course, on the way out to the fishing site, I passed out and fell asleep because it crosses the blood-brain barrier and it causes drowsiness. Also, it can work well for Parkinson's disease. It's used to treat tremor due to significant anticholinergic effects. So we'll talk about that a little bit. Insomnia. So remember I said earlier how we can actually use the side effect of the drug as a treatment for the inability to sleep. So yeah, it might dry you out a little bit, and if you don't have allergies, you may feel a little drier, a little more hoarse with this, but it will help you sleep. And then, and in fact, Benadryl, diphenhydramine, is in many nighttime preparations. So you see like Tylenol PM. Tylenol PM is just Tylenol and a little Benadryl. But they mix it together. They charge you more than what you would pay for both of those drugs individually. And then, tell you about how it's going to help you sleep. It's all marketing, my friends, and this is where big pharma comes in, and pharmacology and selling drugs is a huge moneymaker in the United States. And then the last thing is urticaria, hives, which are often caused by histamine release. And we will often see urticaria in severe allergic reactions. So if you have a patient who, let's say they have a blood transfusion, and 30 minutes into the blood transfusion, they begin to get hives. That can be an allergic reaction. It could be to a chemical that's being used. It's in the blood to keep it liquid and ready to go. It could be due to a lot of different things. It could be to the plastic that the blood is in, the plastic bag, and maybe some of those metabolites. But anyway, it could be that the blood is not a good match for the patient. So they'll have urticaria, big hives. You would stop your transfusion, you would start normal saline, and you would give them this H1 receptor antagonist. And our drug of choice is Benadryl, diphenhydramine. Now, I have two pictures on here, one of a syringe and one of a bottle with the tablet. So Benadryl comes in both of these forms. You can give it IV, you can give it PO, and there are actually even some topical versions of Benadryl, like Benadryl gel and some other things. I don't know how well those work, but I do know from my own personal practice as a nurse that I have given thousands of milligrams of Benadryl, both by injection and by mouth. So again, it's pharmacologic classes. It's an H1 receptor antagonist, antihistamine. It's first generation. So remember, we're going to talk about Claritin in a minute, which is also an antihistamine, but it's second generation. So, came along a little bit after Benadryl, actually quite a long time after Benadryl. And they made it so that it doesn't go across the blood-brain barrier. So people could take Claritin every day to control their allergies and still function. They could still work and feel good and not feel sleepy and like, you're ready to take a long nap, which is how you feel often when you take Benadryl. So it's an H1 antagonist used to treat minor symptoms of allergy and the common cold. And again, it's all those cold symptoms that mimic allergy symptoms. So congestion, runny nose, just itchiness. So this is often found in combination with decongestant, analgesic, and expectorant formulations and sold over the counter for cold and flu. Again, NyQuil, anyone. Look at NyQuil. It either has diphenhydramine in it or it has chlorpheniramine, which is another H2 antagonist, another antihistamine. So you'll find that it's often used in the hospital setting. Diphenhydramine is as a pre-medication. Again, it's better as a preventer than it is as an actual reliever, although we tend to use it for both. But it's a better preventer than it is a reliever. And so we'll use it for things like pre-medicating for, again, a blood transfusion if they've had a reaction in the past. Or maybe they're going to get a medication like vancomycin or some other medication that often patients struggle with, have some kind of allergic or other reaction to. So we can give Benadryl ahead of time, 15, 30 minutes, and maybe help prevent that reaction down the road. I know we gave it a lot for chemotherapy. Again, more, I think, as a sedation type of anti-nausea medication. So we give Benadryl and Zofran and wait 30 minutes and then give chemotherapy. Adverse effects, significant drowsiness. That is the number one thing of this. And it's very, it's related to the fact that it's first generation. So again, first generation just meaning older, discovered first. The thing is, if you take Benadryl long enough over time, that tiredness can diminish. So people can get kind of used to it, so to speak. But it takes quite a while. Now, here's something very interesting and something that you need to know is that in children, instead of being this lovely little nighttime medication that you could give, it can actually cause something called paradoxical excitation, meaning even though it crosses the blood-brain barrier and we know that it normally makes kids sleepy, this drug can also cause them to be totally amped up, kind of hyper excitable, running around, kind of crazy. So I've often heard this medication called Mother's Little Helper, and people will give it to their kids like before they get on an airplane or something where they want them to kind of relax and go to sleep. And then, surprise, you have a child who has this paradoxical excitation. So something to be aware of. It also has a lot of anticholinergic effects. So remember, anticholinergic, it's going to be more like dry mouth, tachycardia, but it can cause mild hypotension in some patients, which is kind of interesting. We don't want to use it in patients that have benign prostatic hyperplasia because it can increase their the swelling in those tissues and cause blockade. We don't want to give it to people with narrow angle glaucoma, anybody who has a GI obstruction, and then use cautiously in patients with asthma, mostly because that it dries up secretions, which you would think is good, but that could exacerbate asthma in someone. We need to be lubricated in there. We don't need a lot of extra mucus like we see with an asthma attack, but we do rely on our lungs to be moist to continue to bring up foreign bodies. So if they get too dry in there, it could precipitate an asthma attack. Okay, our next prototype is Loratadine, better known as Claritin. And this is essentially Benadryl without the sleepiness. Again, H1 receptor antagonist used to treat allergies. Many people will take this every day when they're in their allergy season. Maybe things are blooming or spring is here. And it treats minor symptoms of allergy. So it helps with itching, watery eyes, runny nose, sneezing, and it's long acting. So you only have to take it once a day. Benadryl only lasts for 6 hours. Claritin lasts all day long. It can be used in children and the elderly, which we want to be careful doing with diphenhydramine. So Loratadine has a better safety profile for older folks. And it can cause headache, dizziness, and GI distress. So a little bit different in terms of some of the side effects. You don't want to use this in children under 2. It's not been shown to be, it's not been tested for safety that way. And you also want to be careful in asthmatics. And I think this is really interesting. I think the thought is, again, it's a sympathomimetic. So from that standpoint, you would think, oh, bronchodilation, we're good. But the other side of it is that it can dry up secretions, and that can be bad. So you just want to use it with caution. I have to tell you, I've taken Claritin for years with my asthma, and frankly, I think it helps. So not my breathing so much, but just my overall allergic status. And when that's controlled, then my asthma seems to be better controlled. So nursing considerations for this one is you really need to teach people how to take this because overdose can lead to Loratadine toxicity, which includes cardiac, renal, and hepatic problems. So especially in older folks who may already have these issues, right? They can safely take it as long as they take it according to the way it's prescribed, which is once a day. So just want to be really clear that they have a plan for how they're going to make sure they don't overdose on that and all the other many drugs we give them. Okay, nasal corticosteroids. Do you see how often steroids come up, folks? We use them for everything. So they reduce nasal what? What do corticosteroids reduce? They reduce inflammation. They're the preferred drugs for allergic rhinitis treatment, much more preferred over antihistamines, and we'll talk about Intranasal corticosteroids have almost no long-term effects due to the fact that the drug's only administered right to the target tissue, right? Just a nasal spray. Decreases the secretion of inflammatory mediators like histamine, which reduce tissue edema and cause mild vasoconstriction. There's no immediate benefit, though, to these. So just like we talked about beclomethasone for asthma, taking a steroid inhaler, that in the moment of an asthma attack, it's not going to help. But long-term, taken long-term, becomes one of those preventer medications, right? So same here with these corticosteroids. They have to be taken for 1 to 3 weeks before benefits are seen. And again, you want to start taking them early in the season when there's seasonal allergies. So when things are just starting to bloom, that's the time to get going. Many of these are available over the counter. You can buy them without a prescription, which is pretty awesome. So our prototype here is Fluticasone or Flonase. And again, I have a nose because this is a nasal preparation that we're talking about here when we talk about Flonase. Now you need to know that Fluticasone comes in lots of formulations, right? So look at here, it's a drug for asthma, rhinitis, so allergic rhinitis, asthma, and skin inflammation. So you must be able to put it up your nose, inhale it in your lungs, and smear it on your skin, which you can. So it comes in a nasal spray, an inhaler, a cream, and it may come in even more preparations than that. So I just want you to know that when you see Fluticasone, you can't just assume oh, that's inhaled or oh, that's a nasal spray. You have to know how it's being given. So again, corticosteroid, it's used to decrease inflammation in nasal passages, thereby reducing stuffiness. And there's some new formulations that combine like an antihistamine with a corticosteroid, which is pretty cool actually. So you can see how the two of those together, one, it reduces the number of things you have to spray up your nose. And two, the two of those together might do a really great job of reducing inflammation and then reducing the symptoms that happen with histamine release. And then adverse effects are super rare. Just the fact that you're spraying something up your nose can always mean like nasal irritation and nosebleeds, mostly because, especially if it has an antihistamine in it, it can really dry out your tissues up there. And then I don't know if any of you get nosebleeds when it's dry, but that can happen. And then, yeah, you're bleeding all over the place. Not fun. Contraindication is just known hypersensitivity, people who have an allergy to this. Now, the other people who should not take this, and this will make total sense if you think about, like, we talked about beclomethasone and how you have to rinse out your mouth. And if you don't, you can get basically an oral yeast infection, a candidiasis in there called thrush. Well, with the nose, you don't want to use this if somebody already has a known viral, fungal, bacterial, or parasitic infection, especially in the sinuses or the nose. So it shouldn't be used during that time because, again, this is going to decrease the immunity or the immune response that the nose and sinuses can mount. And so that's good from an inflammation standpoint. That's bad from an infection standpoint. So I hope that makes sense. We can talk about it more in class. Nasal decongestants. So now we're getting into things like Sudafed and that kind of stuff. These are used to relieve nasal congestion. Most are sympathomimetics. They have alpha adrenergic activity. Remember, alphas relate to vessels and vasoconstriction. They're very, very effective. So I don't know if you guys have ever had like totally runny nose and you use like Afrin and you spray it up there and all of a sudden it's like, woo, you can breathe, you can smell, and your runny nose stops, and that's great. But the problem is you can only use it for a few days because eventually our bodies get used to that. And when you don't give it, you can have this thing called rebound congestion. So, you're taking it to prevent congestion, but in rebound congestion, you stop taking it and you have worse congestion. So you don't want to do that to yourself. So if you're going to take it, just take it for a few days, hopefully to just get you through the worst of whatever kind of, congestion you have. And then you're good. So people who are dependent on intranasal decongestants or use them a lot really should switch over to intranasal corticosteroids, because those don't cause rebound congestion. And yes, they're going to take 1 to 3 weeks to work, but ultimately reducing that inflammation should do the same thing and cause you to not become congested in the first place. Prior to 2000, Sudafed or pseudoephedrine was the most common decongestant in over-the-counter cold and allergy medicines. However, it can be used in the illegal synthesis of methamphetamines. So, you can still buy it. Like I absolutely love Sudafed when I'm sick. It works way better than the other kind of fake Sudafed, which we'll talk about later. And so I won't hesitate at all to go to the pharmacist and say that I'd like Sudafed. And what they'll do is they will check your ID. They will write down your name and your address and how much you're purchasing. There's a limit on how much you can purchase. Of course, you're just going in for a cold, no big deal. And then you're fine and you can take it and you're good to go. They're trying to prevent people from buying it in bulk so that they can go and make meth. So it can still be purchased over the counter, but again, you are not going to get it off the shelf. You're going to have to actually go up to the pharmacist and get them to give it to you, and then you'll have to sign for it and show some ID. But again, so when I'm talking about that, I'm talking about Sudafed that's a pill, whereas up here we're talking about nasal decongestant. So I just want to be clear about that. I'm going to move us forward. So the nasal decongestant, that's our prototype, is a spray. It goes up the nose. We're not talking about a pill right now. And it's a sympathomimetic, and it's called Oxymetazoline or Afrin, or, Rite Aid brand nasal decongestant. I mean, you'll see this as the generic, right? And then it'll have 1,000,001 brand names. But probably the most common that we know of is Afrin. So through alpha adrenergic stimulation, it causes the arterioles in the nasal mucosa to constrict, drying the mucous membranes within minutes, and it lasts 10 or more hours, so it's great. It can also be used in eye drops and relieves like redness and provides relief of minor eye irritation. So a lot of times like Visine and some of those that actually clear up redness actually have oxymetazoline in them. The adverse effect, though, is rebound congestion when you use it for longer than 3 to 5 days. 3 to 5 days, not a big deal. I don't think there's anything magic about 3 versus 5. You may have minor stinging and dryness in that nasal mucosa because it's going to shrink up those vessels in there, right? Which is going to dry out those tissues. But that's okay. That's good. So, nasal decongestant along with a nasal corticosteroid, you can see how that could be very powerful. Okay, last thing we're going to talk about is cough. I just want to remind you that cough is a natural reflex. It's a symptom, can be a symptom of often like common cold, allergies, asthma. Could be that the patient has a chronic lung condition like COPD. Maybe they have cystic fibrosis. It can be a sign of a tumor, but again, this is the rarity right here, but it can happen. And then bacterial, viral infections. cough is really just our body's way of trying to clear excess secretions in foreign bodies, right? So if we have an infection in our lungs, our body's way of getting rid of that is to surround it with mucus, right? And then we hopefully cough that up and out. And eventually, over time, between that and our immune system, we can fight whatever it is that we have. It's actually not desirable to suppress the normal cough reflex. But if you've ever heard someone who's just hacking and coughing repeatedly, that gets very old and very tiresome for the person who's doing the coughing, and can interfere with rest and really just sort of your daily activities. So really prolonged cough, you know, is when we start to think about taking these cough medicines. Coughing can be really irritating to the membranes of the throat, but in general, it doesn't really hurt us to cough. It sounds awful. It doesn't feel great to do it, but the biggest issue is that, we just tend to sort of run out of steam and, can't lay down, we can't sleep, can't get any rest. Now, I do want to say that prolonged cough with or without treatment, and we're going to talk about antitussives, which means against coughing, requires the patient to be seen by a healthcare provider. So if somebody tells you, I've been taking cough medicine for a week and nothing's changed, they need to be seen. There's something else going on, or they need to make sure that nothing else is going on and that they're still just maybe slowly kind of crawling out of the hole from whatever flu or cold they had. But you don't want to let people, if somebody says, I've been coughing like this for 3 months, that there's something else going on. There's an asthma or there's some kind of reactive airway issue happening. So antitussives, aka cough medicine, and our prototype actually is dextromethorphan. Just realized I did not do a great job on your prototype slide here. But it's basically an antitussive and a cough suppressant. The best antitussives actually are opioids. And even though you're not learning this right now, what's here on this side of the slide, I just want you to see that opioids are used sometimes as antitussives. And if you've ever had like Robitussin with codeine or dextromethorphan with codeine or hydrocodone, those are incredibly effective if you cannot sleep because you've been coughing. They're great. And the way they work has nothing to do with your throat. So I'll just tell you a funny story. When I was a kid, my mom, I would take cough medicine, this hideous, nasty stuff. And then my mom would not let me drink water for like 10 minutes because she's like, that's how it works. It has to coat your throat. Well, that is not how it works. It works in your brain. So actually take a big swig of water with that nasty cough medicine and get it out, get it down into your stomach so that it can get absorbed, because it works in your brain. And it tells your brain you have a cough center in your brain, and it tells it to calm down and not cough as much. So, and it raises the cough threshold, meaning that your body, it's sort of like setting the thermometer in your house or the thermostat. Like the heat's not going to come on until it's, 60 degrees in your house or 62 degrees, wherever you have it set. It's the same here, that it makes it so that you can tolerate that desire to cough longer before you cough. So that's what it means by raising the cough threshold. You're not going to feel that sensation because it's raising the threshold in your brain that says, no, I don't need to cough yet. Nope. Even though, inside your lungs might be like, I don't want to cough. So that's why you want to be careful, because it can suppress a cough. So dextromethorphan Non-opioid antitussive works in the brain, and it's chemically like an opioid, but it doesn't have any of the addictive properties of opioids. So that's why it's sold over the counter. And again, this is your generic run-of-the-mill cough medicine that you see. They almost all have dextromethorphan. The problem with dextromethorphan is if you want to abuse it, it can be abused and can be taken in excess and cause hallucinations, slurred speech, dizziness, drowsiness, euphoria, and lack of motor coordination. If anyone thinks that's fun, I feel sorry for you, but it has been abused, and it's been abused by mostly by teens and young adults. Opioids, on the other hand, you will have to get a prescription for that, cannot be sold over the counter, and you have to be careful because we know that opioids can cause respiratory depression. So if you decide, wow, this stuff's really awesome and I don't want to cough all night, I'm going to drink half the bottle, you could actually to take enough that you would knock out, your respiratory drive. So again, you want to be really, really careful. It's got low abuse potential, but some, and it really shouldn't be used in anyone under the age of 18 years old. So I'm really sorry I didn't make this super clear, but dextromethorphan is your last prototype. So all your prototypes are in that second slide where we did our little quiz. All right, guys, I hope this helps, and look forward to talking more about it in class.